And I think we'll get started. Okay. I would like to introduce Dr. Amer, who is going to present today our pain and addiction update on management.
I'm Dr. Amer. I'm the medical director of the adult unit here. And boy, if there's ever a topic that was more controversial, I don't know if you found one. And this can also be described as the real pendulum topic over the years. Nothing has changed I've been here for a long time, from one philosophy to a different philosophy and back to the same philosophy. It keeps going back and forth in terms of how to treat this problem of pain and addiction when they exist at the same time. About 20 years ago, I went through some old notes and I gave several talks called Prescription Drug Abuse, Prescribing Practices. One was called How to Beat the Con. And the talk, this talk had as its impetus my going to a conference in New York this spring in March, given by the Beth Israel Pain Institute on the clinical use of drugs of abuse. And it was really a good conference, but it was sponsored by a pain center. And their whole worry is over the years is, what are we going to do about this problem nationally of untreated or poorly treated pain, which they present a good case as a real problem. And then there's the addiction field that we have this coalition now going on, opioid coalition, to deal with the problem of opioid addiction in the Twin Cities, which was started by Mary Kay Borgstrom, a nurse on 3A. And at the last meeting, there was this feeling that, again, what are we going to do about the problem of drugs? Why are doctors prescribing all these pain medications? They're so addicting, it's way out of hand. So to try to come to some reasonable compromise or understanding about this is the purpose of why I went to the conference and the purpose of this in-service. So 20 years ago, the theme was that doctors overprescribe pain medication, that they malprescribe pain medication, that addiction is unrecognized, ignored, and aggravated by the prescribing. Then the message was that remember addiction in terms of whenever you're prescribing, doctors should always remember the disease of addiction, and if it's there, don't prescribe opiates. Plain and simple, that's all you have to do. But sometimes alternative treatments for pain aren't enough. Sometimes the pain keeps going on. Sometimes patients with the disease of addiction just don't get relief with the alternative treatments, and should they be told, tough beans, just live with your pain? And is it true that patients with addiction cannot be treated with opiates? I'd like to quote from Russell Portnoy, who was the director of this conference that I went to. He said that the capability of medical providers to meet the imperative to relieve suffering would be largely unmet if it weren't for opioid analgesics. But recreational or experimental misuse to self-medicate against mood disorders and compulsive use driven by uncontrollable craving can lead to illness or even death and dramatically undermine public health. The dichotomous and sometimes paradoxical reality of the potential good, which is relief of pain-related suffering with the mitigation of associated morbidities, and the potential bad of opiates, toxicities, and addiction liability have confronted and confounded physicians for centuries. So that's what we're dealing with as we start this conference. To begin with some definitions. The first is the definition of addiction, which most of the people in the chemical dependency program should know. Addiction is a pathologic process with characteristic signs and symptoms. It's definitely a disease. It's a primary chronic disease with genetic, psychosocial, environmental factors influencing its development and manifestations. It's often progressive and fatal, and characterized by continuous or periodic loss of control, compulsion or preoccupation, use despite adverse consequences, distortions in thinking, most notably denial. That's how we diagnose the disease, not the behavior, but the disease of addiction when those are present. But then we have another disease, which is recognized nationally by the medical community as also a true disease, and that's a disease of chronic pain. It's not just appendicitis causing pain, or it's not just back causing pain. Chronic pain can be an entity in itself, a disease in itself. So the definition of pain as a disease is a chronic disease in which homeostasis is altered. As recognized alterations in receptors, genes, ion channels, all discovered by research. Evidenced as a disease is supported by functional MRI brain changes, and it leads to adverse effects. People with chronic pain have adverse effects on activities of daily living, on mood, on family, work, relationships, finances, and spirituality. Chronic pain is like addiction in that it's also manifested by loss of control of pain, just like the addicted person has loss of control of their chemicals. The person in chronic pain cannot control what's going on, cannot control how they react to it, cannot control how they feel. Preoccupation with pain, that's all that they can think about. Just like an addict, all they can think about is the chemical. So all aspects of chronic pain and all aspects of addiction as diseases are very similar. In the past 25 years, there's been a rapid increase in opioid prescriptions. And there's also been a rapid increase going right along with that in diversion, addiction to opioids. That's what we see on the unit now. We're just seeing tons and tons of people addicted to oxycodone, OxyContin, hydrocodone, and others. And there's been a rapid increase in overdoses, deaths due to prescription opioid addiction. So the focus has switched back, as I mentioned when I was talking about this pendulum, from pain as the problem to opioids are the problem again. It started with opioids was the problem that I was talking 20 years ago, and then it went into a phase where pain was the problem and we shouldn't really worry about the pain medication. Now it's back to opioids are the problem. Opioids are the #1 drug of abuse. This in 2011, the #1 drug of abuse, greater than marijuana. It's the #1 drug of abuse. The most prescribed drug of all the prescription drugs, more than Prilosec, more than Lipitor, more than amoxicillin, more than Z-Pak, the #1 prescribed drug in the United States is hydrocodone or Vicodin. By far, that's the #1 drug. Why has there been an increased use? Couple reasons. Increased prevalence of poorly controlled pain. Combating opioid phobia. That was something that in the middle of the pendulum when it was switching to why aren't we prescribing enough pain medication, they talked about opioid phobia. Doctors are afraid to prescribe these medications and they really shouldn't be. You can prescribe this stuff. It's not going to be a problem. There's lots of evidence that shows that when you prescribe it, addiction doesn't turn out to be a problem. So we were taught and told, don't examine pain, get a pain number. If they're in pain, go ahead and prescribe. Relieve suffering. So there was a combat against opioid phobia. Why also there's been increased use? There's a misperception that cancer pain and non-cancer pain are comparable, and they're not. They're very different types of pain, very different patient populations. Another reason that opioid prescriptions increased was data from palliative care research, people that did need treatment for their cancer pain, their hospice patients. There was great data that shows that if you give them enough morphine, if you give them enough oxycodone, if you treat the pain and you do it right, the outcome is much better. good evidence to support that. So then people just generalize that to the pain population. It must be the same. Just all we have to do is prescribe more pain medication, and it's got to be the same. There's no evidence to support that. And at this pain conference, they emphasize that, there really isn't good evidence that treating chronic pain in the non-cancer patient long-term with opioids improves outcome. The evidence is lacking. There's no good evidence, best practice evidence, that treating with high-dose opioids improves outcome. The evidence is lacking. But one of the speakers at the conference had a great quote. He said, the absence of evidence is not evidence of absence. I thought that was a good one. Meaning just because there's no data to support it yet, they're still doing the research, they're still looking at it, does not mean that using opioids in a higher dose or for a longer period of time for the right patient in a monitored manner is not a good thing. Using opiates to treat non-cancer chronic pain may very likely be best practice. So prescribing thoughts. When I have to do this in my practice, I'm a family practice doctor. I see lots of patients in chronic pain. I see lots of patients with addiction because of who I am. So I see a lot of people are referred to me. Now a lot of people are coming to me with pain. So you have to weigh the pros and cons. So as I'm thinking about prescribing, I have to go through what are the benefits of prescribing opiates? What would be a good reason to do it? Obviously, to reduce pain, to reduce life impairment, to improve function. A patient that's on the opioids should be able to get around doing their activities of daily living better, should be able to work better, maybe get back to work. Improve psychological distress. If you've seen somebody with chronic pain that is just miserable, can't do anything, has become so depressed, so addicted or whatever, and then their pain is controlled, to see the change, it's really amazing. Address pain as a malevolent force against the health of an individual. So then you also have to think about what are the risks? What's going to happen? If you're seeing somebody with addiction and chronic pain, do you just say, well, we're not going to use opiates? But you can't just say, well, let's give them what they want. There's risks too. There's the risk of not treating. There's the risk of the disease of addiction. We'll get to that in a minute. The risk of not treating. When I was preparing this talk, I decided I don't want to just come at this from the pain doctor's point of view. I want to also bring in the addiction doctor's point of view. So I pulled out from the American Society of Addiction Medicine, the textbook of addiction medicine, and went into the chapters on pain treatment and found some interesting quotes. I hate to just read, but I'm going to read a couple quotes. This is from the addiction medicine textbook. When there is doubt regarding whether a patient is in pain or is requesting drugs because of an addiction, it is medically appropriate to err on the side of giving adequate pain relief. Physical dependence on opiates is reversible. Addiction is treatable. It is acceptable to be deceived from time to time if it means providing effective pain relief to the majority of patients who truly need it. It seems more likely that under-treatment of pain in an individual with addictive disease will increase distress and anxiety, increase pain, and thus present a more potent risk factors for relapse than simple exposure to dependence-producing medications. I thought that was interesting in that where it came from, the principles of addiction medicine. The risk of the disease of addiction is that what I've always known and what I've always taught is that disease makes people different. Addicts need to be treated differently. Addicts have lost endogenous mechanisms to control pain. They're much different than the general population if they have the disease. They have more pain when they're in withdrawal. They have wide swings in muscular tone. They have wide swings in mood. my image, and I just was seeing a patient this morning with chronic pain, and now she's on buprenorphine. She's became addicted. She just finished treatment, and she's doing great on the buprenorphine. Very, very low dose. But she says this is amazing in terms of how this is controlling my pain as opposed to all the narcotics that she became addicted to. But my image is that people with the disease of addiction have tons of opioid receptors that are just sitting there in their brain. And when they get pain, these opioid receptors open up. Now, this isn't science, this is an image, so take it for what you want. But people with the disease have these receptors that are crying out, and they're crying out to, the way they cry out is by creating pain and by creating craving and by creating preoccupation. So that's the addict. And they need to be filled by opiates. They beg to be filled by opiates. Blocking these receptors, not necessarily stimulating them with an opiate, but blocking them with a drug like buprenorphine, reduces pain and reduces craving. These receptors that were open and asking, all of a sudden aren't asking anymore, and the pain gets less and the craving gets less. That's why it seems to be such a good drug. I had another patient who became addicted to the fentanyl patch. Well, he was on oxycodone and then the fentanyl patch and was on massive dosages. He had lupus, and then he had arthritis and horrible, true pain. Never was an alcoholic, never really was an addict. But he came in and we detoxed him off his fentanyl patch, and he's on 2 milligrams of buprenorphine twice a day, and I've seen him now for about 5 years. He has no pain on this tiny dose of buprenorphine. He says, this drug is amazing for my chronic pain. So that's just another example. Best example of how, I tell this to a lot of different patients that I talk about. I tell this to patients on 3A when they're coming off of opioids, in terms of understanding that pain in the addict is different than the pain in the non-addict. Years ago, I had 2 patients. Both had total knee replacements. Both had it at Fairview. Both had the same operation by the same surgeon on the same day at Fairview here. One was a 50-year-old housewife. The other was a 50-year-old chief executive officer of a company who was a recovering alcoholic, 10 years sober. They both went through surgery. They both went to the post-op room and then to the orthopedic floor. After surgery, the 50-year-old housewife, who did not have addiction, I think she took a couple Darvon and then some ibuprofen, and that's all she needed. The alcoholic, the executive, he was in there with the patient-controlled anesthesia, and he was pumping this button. He was screaming out. He was asking for morphine. He wanted Dilaudid. It was unbelievable. His pain was wild, totally uncontrolled, needed lots of narcotics just to satisfy him. Same pain, had to be the same pain. It was the same surgeon, same knee, same operation. Interesting example. So I've always known the chronic pain in the patient with addiction is different than it is in the patient without this disease. The pain in the patient with addiction is a diffuse pain. It's amplified. They will describe it in terms of superlatives. You're always going to get a 9 or a 10 or 11 or 12 or something. It's a constant pain. It doesn't really seem to fit in terms of what's wrong. It's there all the time. Patient's hyperreactive. And why is that? The patient is also globally distressed. Why is the patient with addiction and the patient without addiction different? This was brought up at the pain conference that I went to in March. This whole concept of hedonic tone, which I've always liked. Hedonic means pleasure, something that gives pleasure. The word anhedonia means an inability to experience pleasure, which sometimes addicts get in the post-acute withdrawal syndrome. But hedonic tone, addicts have less. The theory is that addicts have less hedonic tone. And chronic pain patients may too have less hedonic tone. Both do well when they're given opioids. Maybe both have an endogenous opioid deficiency. Both groups respond to antidepressants, somewhat, chronic pain patients and addicts. Maybe the reason they respond is because of improved hedonic tone. Hedonic tone is improved by social connectedness, like AA. Hedonic tone is improved by spirituality. It's an interesting way that spirituality may enhance a person's recovery. What do addicts say when they're first placed on buprenorphine? They use quotes like, "It gave me my life back." For the first time, I feel normal. It was as if they never felt normal until they got these receptors filled and they started to have improved hedonic tone. Pain relief with addiction recovery. This is on the other side. There are many cases that get better without getting opioids. People with addiction that when they treat the addiction, they seem to get better. Just recovery from their addiction is what will turn them around. Numerous cases over the years I've seen of a reduction in pain when they simply recognize their powerlessness over the chemicals. They recognize how their pain is unmanageable, and they work a 12-step program. That's possible. Many of you know who have worked on 3A or in the treatment program, David, the story of David, who keeps coming by, and I think he still gives AA meetings. This was a man I had many years ago when we were in the other building. And he showed up addicted to lots of pain medications, and he brought in a box this high of his medical records to prove to me that he had something that's going to need treatment for his pain. And he had cervical disc disease and low back pain. So anyway, he was addicted to benzos and opiates, and we detoxed him off of both, and then he went to treatment, and then he got into the recovery, and he just did great. He came in a wheelchair and left walking up and down the halls. He always said when you would ask him that the pain is there, but it doesn't seem to control me anymore. He's fully active and independent in life, and I still see him, and he's just doing fine. He recovered from his chronic pain by focusing on the addiction. So then one more quote from the Principles of Addiction Medicine, the same textbook. We continue to be amazed that the most grateful patients are not necessarily those whose pain has been abated in response to pharmacological intervention, in other words, getting pain medication. Large numbers of patients report that their pain is little changed from admission, but they laugh, walk briskly, take no controlled drugs, and assure us that their suffering, not their pain, but their suffering, has largely been alleviated. They are optimistic and report that the pain is on the back burner where I don't much think about it. So many patients with addiction seem to have more pain when they are on opiates. You treat them and they get worse. And this was always my theory many years ago. You have a patient with addiction, you give them some Vicodin, you give them some oxycodone, and their pain actually can get worse if they have addiction. That's why this is such a controversial topic. The pain can be increased because of intermittent withdrawal. If you don't give the right one, the opioid goes into their body and then leaves, goes in and leaves, up and down. So intermittently they have withdrawal, and the withdrawal creates increased pain. High levels of sympathetic arousal, increased muscular tension, increased depression because you've activated their addiction, increased anxiety. And so that would be one that would not turn out well with the chronic usage of opiates. So again, back to the office, you have somebody with addiction, you have somebody with true chronic pain. How do we manage it? Suppose that you are going to decide, I'm going to treat this person with pain, but how do I manage it? First thing is drug screens. These have to be done. They should be done. Doctors are frequently reluctant to do it. A couple reasons to do the drug screens are, one that people forget about is to screen for compliance. to make sure that they're taking the drug that you're prescribing. If you do a drug screen and there's no evidence of the drug that you're prescribing in there, they're likely selling it or diverting it. And to screen for aberrant behavior. Doctors are notoriously wrong when they are asked to predict which ones of their patients are using, which ones aren't. What are the drug screens going to be like? I think it was like 30% correct when they studied a group of doctors in terms of how they predicted it. So the word is, and the saying is, to trust the patient but verify. Informed consent. When I'm seeing somebody with addiction and pain and I'm thinking they're going to need pain medication, you should do an informed consent. You need to specify the goal. What are we trying to do? You need to document the risk, benefits, and alternatives. You have to state to these people that, we may put you on something for pain and we may not be able to get you off. Maybe a lifelong treatment. In medicine, there are a lot of diseases for which we have a lifelong treatment. Informed consent clarifies shared responsibility. Patient agrees to be active in improving their health, to do what you say. Doctor agrees to treat, to prescribe, and to manage. And then a pain agreement. If we're going to do this, you should have a pain agreement. It should be documented in the chart. You probably can't see this, but this is just, you don't need to see all the small print. But this is simply something that from the American Academy of Pain Medicine, a sample of a long-term controlled pain agreement that I use in my practice that specifies things like you're not going to be getting early medications, refills. If you lose it, you're out of luck. We're going to be doing drug screens that you have to show up for visits, et cetera, et cetera. So we have people do that, and we begin treatment as a trial. So the next thing is assessment. A doctor that's going to be treating pain with pain and addiction shouldn't just say, okay, low back pain, I'm going to just prescribe them this and forget about it from there on. You got to know what you're treating. You got to know its state. You got to know about what you're treating that's causing the pain. So where is the pain? What are the aggravating factors? What are the alleviating factors? You need to have the patient come back periodically and assess the need for more studies to see where the pain is, to assess the ongoing need. We should consider switching to a long-acting opioid instead of a short-acting opioid because that's what is best practice. Now, how do we manage to reduce risk? There are lots of information now about abuse-deterrent opioids. The best example is OxyContin. Used to be a tablet that could be crushed, and then crush can be dissolved, and that could be injected. The addicts would just crush it in their mouth. That way would get the long-acting to immediate acting. They would crush it and snort it, immediate acting. So they changed the formulation of OxyContin to a tablet that can't be crushed. And even if you did crush it, the pieces of crushed stuff that you have is also long-acting. So it really does avoid the immediate pow effect of the OxyContin. And the addicts were pretty frustrated. You can get a lot of money for the old OxyContin, but the new OxyContin has less of a street value. Suboxone is an example. In buprenorphine, there is naloxone, which prohibits or prevents an addict from taking this pill, crushing it, and injecting it, because that would put them in withdrawal. It's an abuse-deterrent opioid. The addicts want it right now. There's a new formulation coming out where they're taking oxycodone, a long-acting one, and putting niacin in it. Niacin is a drug that's used for high triglycerides. One of the main side effects of niacin is it causes flushing and itching. Horrible side effect. In a low dose, it doesn't cause that. So ingeniously, they took the pain medication, put niacin in there. If you take more than prescribed, you're going to get flushing and itching. You're going to pay for it. Aberrant behavior. Boy, if you treat somebody with addiction and chronic pain, you're going to see this. And then you got to decide. Positive drug screen would be an example. Losing the prescription, missing appointments. Do you discontinue it or do you continue to treat? Do you send them to treatment? So a lot of decisions would need to be made.